Thank you so much, Adrian. Thank you for the invitation and for letting me speak tonight. So I'm going to share my screen now. I'd like to talk today about updates in preventive cardiology. So many of the things I'll talk about are based on guidelines from both the American College of Cardiology and the American Heart Association. And they last updated the guidelines on primary prevention of cardiovascular disease in 2019. So the first important question to ask is what primary prevention is, because that's the focus of my talk. So primary prevention is, simply put, trying to intervene before any health effects occur. We're trying to prevent disease before it happens. So it's obviously very important. Aside from cardiology, you can think of things like vaccinations, like altering risky behaviors, preventing things like poor eating habits or tobacco use, avoiding or reducing substances known to be associated with a disease or health condition. This is in contrast to oftentimes what we see our patients for, which is secondary and tertiary prevention. So secondary prevention would be catching a disease in its early stages. So this includes things like using mammography to catch early stage breast cancer, using regular blood pressure testing at our office visits to catch hypertension in its early stages before it can cause any further damage. And tertiary prevention is what we spend a lot of our time on, which is once you have the disease, trying to treat the disease, trying to prevent further complications from the disease. So these are the pillars of prevention of cardiovascular disease. So I'll talk about each of these in turn, but we always think about things like cholesterol, like high blood pressure as cardiac risk factors, diabetes in addition to that. Things like physical activity, tobacco use, diet, aspirin use. So I'd like to start by going through a sample kind of initial visit for somebody who sees me for a preventative cardiology visit. So this sample patient is named John Doe. He's a 60-year-old male. He presents for initial evaluation by cardiology. He has never seen a cardiologist before in his life. He wants just, when I talk to him, and I ask how I can help him, he wants a cardiology checkup, just as a general, as his general reason for his visit. He's not having any symptoms suggestive of any cardiac disease. He's not having any chest pain, any shortness of breath or palpitations, but he is worried about his heart health just in general because he's had a family history of heart disease with his father having had a heart attack. So the question is how you would approach this patient, what you would start with. So in general, for somebody who comes to me who's aged 40 to 75 and being evaluated for prevention of cardiovascular disease, the first thing I start with is a 10-year atherosclerotic cardiovascular disease risk estimation. So what this is your 10-year risk of having either heart disease or stroke. So it gives a good baseline risk, and it lets me talk to the patient about what their baseline risk is and how we can improve it or optimize it. So you can actually do this yourself if you have a copy of your most recent cholesterol labs, if you have your most recent blood pressure from the doctor's office. But you can see that the risk calculator takes into account several different things. So there are things like demographics, like sex and age and race, things, part of the cholesterol panel, the total cholesterol, and the HDL, which we sometimes refer to as the good cholesterol, the systolic blood pressure, which is the top number of the blood pressure, and any history for the patient of things, cardiac risk factors, so things like diabetes, like smoking, like being treated for high blood pressure. So for John's initial vital signs and labs, his blood pressure is 135/75. His cholesterol panel, I put in numbers there, and I put the reference values so that you can all see what a normal kind of total cholesterol is, a normal LDL, HDL, things like that. And so putting these numbers into the calculator, John's risk is 11.4%. So his 10-year risk of heart disease or stroke is 11.4%. So if we look at how we take into account the risk score, we can separate patients into several different categories. So low risk is anybody less than 5% on the risk score. Borderline or intermediate risk is in between 5 to 20%. And you can see that John would fall into an intermediate risk category. And high risk is anybody above 20%. So you can see at the bottom that lifestyle modification is key for everything. So lifestyle modification is what we start with, what we recommend for everybody, no matter whether they are low risk or high risk or intermediate risk. And I'll talk a little bit more about this CAC score for borderline and intermediate risk patients later in the presentation. And you can see that as your risk gets higher, that's when we start considering medications and drug therapy to try to, for instance, reduce the blood pressure or reduce the cholesterol, treat the diabetes. You know, that's when we consider adding on medical therapy. But like I said, lifestyle modification is important for everybody. So how would I counsel John in terms of his lifestyle, or what would I ask him about, I should say. So the first thing I would ask is about his diet. And we generally consider a healthy cardiovascular diet, a diet that emphasizes things like vegetables, fruits, nuts, whole grains, minimizes things like animal fats, so trans fats, red meat, processed red meats, things like sausage and salami and things like that, refined carbohydrates and sweetened beverages. And we always obviously, at every doctor's visit, take the weight. So for overweight adults, we counsel them on trying to lose weight and trying to reduce their calories so that they can get to a healthy weight, to maintain a healthy weight. So one of the diets that I like to base my counseling for patients on in terms of what to eat is a Mediterranean diet. There are other diets out there, plant-based diets, and there's other types of diets that could also be applicable, but I think this is a good starting point for somebody who just wants a general idea. And it gives a good pyramid of foods that you should try to emphasize, foods you should try to avoid, and foods that you should eat in moderation. It also talks about alcohol and water. So this is, I feel like, a good starting point for people, but I generally try to kind of talk about what they think maybe they could change, what they think maybe they could improve or reduce in their diet. In terms of exercise, what the American College of Cardiology recommends is at least 150 minutes or 2.5 hours intensity exercise, or 75 minutes per week of vigorous intensity exercise. So the question is, what is moderate intensity exercise? So I like this definition from the Centers for Disease Control. So they say that when you're engaged in a moderate intensity activity, you're working hard enough to raise your heart rate and break sweat, and you're able to talk to your friends, but not sing the words to your favorite song. So this includes things like fast walking, like doing water aerobics, like riding a bike, but a relatively easy bike ride that doesn't have a lot of hills, playing doubles tennis, and pushing a lawnmower. So what I try to tell patients to do is try to get 2.5 hours or perhaps half an hour 5 days a week of this type of activity. Or if they want to try to be more intense, they can engage in kind of vigorous intensity aerobic activities. So this is when your heart rate has risen quite a bit. You're not able to say more than a few words to your friend without pausing to stop or take a breath. So this is things like jogging, like swimming laps, like riding a bike very quickly, like playing singles tennis or basketball. So again, 150 minutes of moderate intensity exercise a week, or 75 minutes of vigorous intensity exercise a week, or a combination of both. In terms of diabetes, we consider it a very important cardiovascular risk factor. And for adults with type 2 diabetes, lifestyle changes like the diet I recommended before and the exercise I recommended before are very, very important. And diabetes is such a significant risk factor that they're one of the major groups that we almost automatically recommend cholesterol medications, so statins, which I'll talk about a little bit more later. But they're high enough risk for cardiovascular disease that we would start them on cholesterol-lowering medications, unless, of course, their cholesterol looked ideal. Smoking, we know, has many deleterious health effects, but specifically for cardiovascular disease, smoking is associated with an increased risk of things like stroke, coronary artery disease, peripheral arterial disease, aortic aneurysm. So for every new patient I have, I always ask them if they smoke. If they do, I always ask them how much they smoke, and I always see how willing they are to try to quit. And I try to kind of support them through it if they're willing to if they're willing to kind of take the next step. In terms of blood pressure, they recommend non-medical interventions for all people with elevated blood pressures or hypertension. So I'll talk about that more on the next slide. But for those recommending medical therapy, the target blood pressure should generally be over 130, under 130 over 80. So 130 being the systolic or higher blood pressure, 80 being the diastolic or lower blood pressure. So one important thing is properly measuring blood pressure at home. And this is something that I typically like patients to do because a lot of people get anxious or stressed being in the doctor's office and their blood pressure can be high. But usually what I advise people to do is sit in a chair, kind of feet flat on the ground, sitting straight up and resting for 5 minutes, not checking their phone or watching TV or doing anything stressful. And then placing their arm at the level of their chest, having it supported and not lifting their arm in the air. And so I generally ask people to keep a blood pressure log so that I can get a good sense of what their average blood pressure is at home. If you are all looking for any kind of good blood pressure machines, this website, validatebp.org, has a list of validated blood pressure machines that have been independently validated and are known to be accurate. So in terms of lifestyle changes for high blood pressure, which I was talking about before, they recommend this, like I said, for everybody with high blood pressure or hypertension. So some of the key lifestyle changes we recommend are eating a well-balanced diet that's low in salt, limiting alcohol. So for men, that's fewer than 2 drinks a day, or for women, that's fewer than 1 drink per day. Enjoying regular physical activity. So like I mentioned before, 75 minutes of vigorous activity or 150 minutes of moderate activity. Managing stress in the life, because stress can definitely lead to high blood pressure. Maintaining a healthy weight and quitting smoking. So you can see that a lot of these lifestyle changes are also recommended for the primary prevention of cardiovascular disease. So it's all connected, really, in terms of what we recommend. And it can have multiple benefits, not just for primary prevention or not just for high blood pressure. So if we go back to our patient, I asked him a little bit more about his lifestyle. So John exercises about twice a week. He exercises by playing golf. He plays 18 holes, and he uses the cart. He does try to eat a healthy diet, but he does like the occasional hamburger with fries and steak. He drinks about 6 beers, usually on the weekend. He has no history of diabetes or smoking, and he's wondering, as of right now, if he needs to take a daily aspirin. So, to start with, we can see that John's lifestyle isn't ideal in terms of recommendations for primary prevention of cardiovascular disease. So we certainly have things to counsel him on. But in terms of daily aspirin, it's interesting because it's something that is changing. So from the guidelines, aspirin shouldn't be used very frequently at all in terms of routine primary prevention of atherosclerotic cardiovascular risk because of a lack of net benefit. So these are the old guidelines from the U.S. Preventative Services Task Force, which is a society that tries to address primary prevention for all of health. So not just cardiovascular disease, but they certainly have recommendations for cardiovascular disease. So you can see that this is an old guideline from April of 2016. So at that point, they had said that for adults aged 50 to 59 with a risk score that you calculate over 10%, then it's reasonable to initiate a low-dose aspirin, which is 81 milligrams, for primary prevention of cardiovascular disease. So, and there's some caveats, but patients who are at risk of bleeding, patients who are willing to take a low-dose aspirin, but it's got a relatively strong recommendation of B. And for adults aged 60 to 69 with a similar cardiovascular risk, the grade was C, so somewhat of a weaker recommendation. And then adults younger than 50 or older than 70, it was inconclusive. But you may all have seen in the news in the fall, so around October, you can see that all of these news stories around October 12th, that there was a lot of stories saying that we really shouldn't be taking aspirin, or they questioned the role of aspirin in terms of primary prevention of heart disease or stroke. So the reason this was because the U.S. Preventative Services Task Force had a draft recommendation on that date, on October 12th, that really downgraded the grade for aspirin. So in adults aged 40 to 59 with a 10% or greater risk, it's now a grade C. In adults aged 60, they actually recommend against aspirin for primary prevention. And really the reason this is that they didn't think the benefit of aspirin in terms of prevention was very strong. And they always worried about kind of the risk of bleeding. Aspirin is a relatively weak blood thinner, but we do see bleeding issues with it. So in terms of going back to John, you could see that all of his cholesterol values were a little bit less than ideal. So in terms of cholesterol, what we recommend as first-line treatment for people who require medications is statin therapy. So statins are medications like Lipitor or Crestor or Zocor. Those are some of the medications you may have heard on TV, that you may have heard about on TV or in advertisements. Those are all statins. So who do we recommend statins for? So one thing is if the LDL, or sometimes as we refer to it, the bad cholesterol is over 190. Patients who have diabetes, like I talked about before, diabetes is a very strong risk factor for heart disease. So we generally do start them on statins. And those who we put into the calculator and they have kind of a significant ASCVD risk, we talk about it with the patients to say, hey, your cardiovascular risk is actually quite high. We would recommend a statin medication to try to reduce it. So in terms of John, he, like a lot of patients, is hesitant to take more medications. He doesn't want to take statins. He wants to try to change his lifestyle. So he took some of the kind of recommendations that we talked about with him into effect. He tries to eat healthier, he tries to exercise more, he tries to lose some weight. And after his lifestyle changes, he comes back for follow-up. So his blood pressure is now improved. It's now at our goal of below 130/80. It's 125/75. And you can see that his cholesterol panel has also improved. His total cholesterol and his LDL have come down. And we calculate a new risk score. So this is something I try to do every time with patients, especially when I get a new cholesterol lab. So you can see that his cholesterol, his ASCVD risk score was previously around 11%, and it's now 9%. So it's much better. You know, he's done a good job with his lifestyle changes. But his LDL is still above ideal. You know, his normal LDL is less than 100. So the question is there anything else that can help John in his decision of whether or not to take cholesterol medications or not? So I'm coming back to the coronary artery calcium score, the CAC that I talked to before. So there are tools, and the CAC is just one of them, but it's one of our better tools. But to kind of help further risk stratify patients if they want kind of more than just the calculator. Because as you could see, the calculator doesn't include everything. So the CAC is a coronary artery calcium scan. So it's a low-dose CT scan. We offer this at UCI. It's a low-dose CT scan, doesn't use contrast, and really what it tells you specifically is if there's any calcium in the heart arteries. So obviously the more calcium you have, the worse the risk. So 0 would be ideal. 0 is a kind of a younger, healthier patient who has very, very 0 have a very low risk of a very low 5-year risk of cardiovascular. And then there's obviously grades in between, but the higher your score, the worse or the more risk you have for cardiovascular disease. So what the scan will give you is it'll give you an absolute score for exactly how much calcium you have in your arteries. And it'll also tell you what that is relative to people of your demographic. So people of your same age and same gender. So this is just kind of an example report for John. So you can see that what it tells you is his total calcium is 65. And it also will tell you where the calcium is. So this is a typical heart arteries. Usually people have 2 main arteries, heart arteries on the left and 1 on the right. So John's calcium was predominantly in the left anterior descending artery. in the right coronary artery. And you can see that a total calcium score of 65 for him places him in the 50th to 75th percentile for his age and his gender. So after talking with John Moore, talking about his coronary artery calcium score and his new lipid panel, he decides to take a statin, and he comes back 3 months later for a follow-up. And you can see his blood pressure still remains pretty good. His cholesterol has dramatically improved. And what we're really targeting with the statin is a 50% reduction in the LDL. So his LDL went from around 140s to 80s. And you can see if we put his numbers into the calculator, his risk score has decreased even further to around 7%. So it went from around 11.5% to around 9% to around 7%. So, in summary, the most important way to prevent having to see us for either secondary or tertiary prevention and focusing on primary prevention, trying to prevent the things that we usually see in clinic, things like atherosclerotic vascular disease, things like heart failure, things like atrial fibrillation, is to promote a healthy lifestyle throughout life. And if you all want more information, the American College of Cardiology does have a website, and I believe an app as well called CardioSmart, where you can look up specific recommendations for primary prevention. You can also look if you have known heart disease of any other sort. It has good kind of patient handouts on things like atrial fibrillation, things like heart failure, things like coronary artery disease. So lastly, I did want to put in a plug for the UCI Cardiology Clinic. We have a lot of cardiologists. We're all very happy to talk to you about preventive cardiology and counsel you kind of on lifestyle and things like that. There is a specific preventive cardiology clinic as well, where you can meet with a preventive cardiologist. You can also meet with an exercise physiologist and a nutritionist all at once to try to kind of go over every aspect of your lifestyle. And that program, I believe, offers 1 visit a month for about 4 months. So this is the phone number if you want to make an appointment with any of us. So I wanted to, again, thank you for your time tonight. Thank you for joining. And I will put up kind of my information. And then this is Dr. Deneen's information. She's one of our preventive cardiologists, and she's heavily involved with the preventive cardiology clinic. So I'll stop at this time and take any questions that you all might have.
Thank you, Dr. Huang. Well, you want us to live a healthy lifestyle. We have a question here about, is there a significant risk from taking statins if you have joint issues?
Yeah, thank you for that question. The most common side effect that I hear from patients for taking statins is muscle pains and aches. And there's certainly ways to try to reduce that. There are certainly ways to try to kind of change statins or lower the dose of statins. Occasionally patients need alternative dosing of statins. The statins, unfortunately, are our best medication for reducing cholesterol versus things like niacin, things like fish oil, things like fibrates and things like that. But they do come with that unfortunate side effect of muscle aches. And it's not, I wouldn't say it's a majority of patients who get it, it's a minority, but I think it is a sizable minority who get it. So I don't think that having joint issues is an absolute no for a statin, but you may have kind of more issues with them once you start it.
Okay, we have a question here about your thoughts on niacin versus, it says status. I'm not sure what that means, if it's status or statin.
I think it's talking about statins as well. So niacin is an okay cholesterol medication, but statins in general are the most effective in terms of lowering LDL, lowering kind of total cholesterol. Niacin does have issues. Some patients get flushing with niacin as well. So I would consider it probably a second-line medication if somebody couldn't tolerate statins.
Thank you. You know, I think we're all probably a little surprised about aspirin because we've been
Yeah.
told, you know, over and over, everybody should take a baby aspirin every day.
Yeah, and yeah, that's a good point, and that's why I kind of wanted to talk about aspirin in more depth. You know, it used to be that, you know, everybody thought, well, baby aspirin is it's just a weak blood thinner, it's probably worth kind of the benefit. But when they compare it kind of over large groups of people, they didn't really find a benefit. And I do want to emphasize that I'm not talking about aspirin, for instance, for people who have kind of known heart disease or stents or have had bypass surgery or strokes or things like that, because aspirin definitely plays a very big role in those patients in terms of secondary prevention. So I did get a lot of, you know, in October, I did get a lot of messages from patients saying, hey, I saw on the news that I'm not supposed to take aspirin anymore. And I had to kind of look through each of their kind of histories to say, oh, no, you know, this doesn't really apply to you, or, well, you know, I think that's a reasonable thing, and we can talk about it kind of further in terms in terms of kind of what their personal, you know, risk-benefit ratio is, because obviously that's important.
All right, here's another statin-related question. I recently read that statins raise calcium blockage levels. Is that true? And if so, how do you determine which is worse, high cholesterol or high levels of calcium?
So I have to see the actual study. The things I have read about statins in terms of adverse effects, it does raise the blood sugar by a few points. And I'd have to read the exact study to see kind of if I agreed or not, because it may be kind of a correlation versus causation thing, as in, you know, maybe patients that are more likely to be on statins are more likely to have coronary artery calcium, and I'd have to see how they control for kind of other risk factors, things like other kind of, you know, things like smoking, things like diabetes and things like that. But as far as I know, it doesn't actively promote calcium. You know, that's one of the things we start statins for, is to try to prevent the progression of plaque, progression of plaque, which progression of plaque to kind of further prevent heart attacks and things like that.
All right, thank you. There's a question here about the role of sugar in cardiovascular disease.
So that's a very good question. You know, obviously diabetes is heavily involved with sugar. So diabetics are unable to control kind of their blood sugar. And then one of the kind of risk factors for type 2 diabetes is eating kind of more carbohydrates, eating more refined sugars and things like that. So I would say in as much as it's associated with an increased risk of diabetes, it's associated with an increased risk of cardiovascular disease.
All right, and then we have a question here about other diagnostic tests for indicating heart problems. I mean,
So that's a very
calcium.
good question. Right. So in terms of primary prevention, there's other things like carotid intimal media thickness. So the carotid is your artery in your neck. And so they can measure the thickness of it, and they found that the thicker the layer of the blood vessel in your neck, the higher the higher risk you have. And then there's a lot of other labs that they're looking into now in terms of risk stratification, things like lipoprotein A, things like specific LDL subtypes. Research is still out on them, so that's why I think the coronary artery calcium score as of right now is probably the best test for further kind of risk stratification. Incidentally, you can also see, for instance, if you get a CT chest for another reason, if they're looking for pneumonia or something like that, you can also see calcification in the heart, sometimes incidentally, sometimes they'll say mild or moderate or severe calcification. But unfortunately, those aren't really as well gated towards the heart, so they won't be able to tell you a specific score.
Okay, thank you. We have a mother, I think it's probably a mother, who wants to know if there is a special diet for young children to prevent heart disease as they're growing up.
So That's a good question. I'm certainly not a pediatric cardiologist, and they may be kind of better in terms of that, or pediatricians even. I'm an adult cardiologist, so I do think that, the incidence of kind of type 2 diabetes in children is rising. So I certainly think that, trying to avoid sweets and sugars and things like that is helpful for them. And there are certain patients with a condition called familial hyperlipidemia, where they have a genetic kind of defect in their cholesterol receptors. And so they can actually get very high cholesterol at a very young age. That you can generally tell from the family history. They'll have multiple family members who have perhaps, had cardiovascular disease in really young, in their 30s or 40s or 50s, where you might know about that. But those children obviously have to follow a special diet as well.
And what about surgical procedures that are associated with heart disease?
Sorry, can you clarify in terms of that?
Pardon? I couldn't hear you.
Sorry, can you clarify? Can you clarify about that question?
Well, I think we all know people who've had valve replacements or who have had some sort of artery procedure to clear the calcium or whatever, the plaque. I think these are the sorts of things we might like to know about.
Oh, I see. Yeah, so this in general, as I mentioned, it's talking about primary prevention of cardiovascular disease. So hopefully preventing that surgery. But if somebody does have coronary artery disease and it's very extensive in terms of the number of blockages, what they will consider, they'll first consider putting a stent in. A stent is kind of a small metal tube that opens up the artery. But if there are a lot of blockages and the blockages are really bad places, then they'll consider doing a bypass surgery. So that's your kind of traditional coronary artery bypass grafting surgery. In terms of valve replacement, it's difficult because it really doesn't fit into this talk, because there's if you have valve issues, there's not much that can be done preventatively. There's nothing kind of lifestyle-wise that really contributes to valve issues. It's usually something that you're born with or something that develops over time in terms of a degeneration of the valve and things like that. So obviously this presentation is more kind of for kind of trying to prevent getting a bypass surgery, but I would say for kind of valve issues, it may not be as relevant.
All right. I don't know if this is something within your purview, but we recently read about the heart transplants using a pig's heart. And I know from my own early biology days that the fetal pig is the most like the human being on the inside. And so do you see this as a future for heart treatment?
Yeah, I definitely was following that closely because it's fascinating. There's definitely kind of a shortage of donor hearts, and there's always a surplus of people who need hearts, because as the population kind of ages, there's more people with heart failure, there's more people with coronary artery disease, valvular heart disease, things like that. So I think it is exciting what they were able to accomplish in terms of, I guess they would call it xenotransplantation, or transplanting kind of the heart of another animal to a human. So I think there's probably a lot of work to go in terms of kind of making it more widestream. Because the issue always with heart transplants, even from human to human, is the risk of rejection. So a lot of heart transplant patients have to start a lot of anti-rejection medications, a lot of immunosuppressants, so that their body doesn't reject the new organ. So this is not just the heart, of course. If you're transplanted a kidney or a liver or lungs, it's the same thing. So certainly, it's very promising in terms of trying to solve what is a really big issue, which is kind of the lack of available transplant donor organs. So.
All right, thank you. We have a question here about the risk benefit of calcium supplements for women, because
yeah, so that's a good question. As far as I know or have read, I don't think calcium supplements actually contribute to coronary artery calcium. I think the coronary artery calcium is more kind of a function of atherosclerotic disease. So tends to be risk factors, things like kind of smoking, essentially everything I talked about before. But I don't think the actual calcium supplements have any strong relationship with kind of developing coronary artery calcium. So certainly if you get your blood tested or and your calcium level is low and your primary care doctor or your endocrinologist said you should start taking calcium supplements, I think it's worth it. Certainly there's always aside from cardiovascular disease, there's other considerations for calcium, things like osteoporosis and things like that. So.
Okay, thank you. One of your listeners said, I read recently that a high HDL reading is not necessarily healthy. Do you know anything about this new research?
So yeah, that's actually a very good question. So they found that a subset of patients with high HDL actually, and we usually try to kind of encourage an increase in the HDL by things like kind of aerobic exercise, things like omega-3 fatty acids, those types of things. But a subset of patients actually have HDL that is so high because their HDL molecules are actually defective. So they're actually at kind of higher risk of cardiovascular disease, despite what despite what their risk score might say, despite what high HDL generally means in the general population. So I think they're doing more research into finding kind of how to identify a specific subset of patients. But in general, we still do kind of try to encourage people to get their HDL above 40. And I think I saw a question in the chat about raising low HDL. So things like kind of omega-3, like eating more fish and seafood, more healthy fats, that type of thing. There are also kind of over-the-counter omega-3s that you can take as well. And then exercise generally raises the HDL, like I said.
All right. Are there specific supplements that you suggest for heart health?
So that's a good question. The only supplement that I generally kind of talk to my patients about is red rice yeast. So it can help lower cholesterol. And really, it's kind of interesting because the reason that it does that is that it actually has a statin within it, lovastatin. In terms of other supplements, I saw a question about CoQ10. I think it's CoQ10 is a little kind of the jury is still out on CoQ10. They don't generally tend to recommend it in terms of reducing statin myopathy or muscle aches, but I always think it's reasonable to try it. I don't think there's a lot of kind of harm into CoQ10. And then in terms of other supplements, I always kind of have to do more research into them, but that's kind of the general issue with supplements in general, is that there's not a lot of research or trials and things like that on them. So it just, in general, it's kind of about patient experiences and then what they've noticed.
All right, thank you. I noticed that your charts all seem to stop at 75, and we have a population that's growing older and older, and many, many people living beyond that. Will you be revising the charts, or?
So that's definitely a good point. A lot of the studies, when the pharmaceutical companies do the studies, they have a specific patient population, so they'll stop it for kind of higher risk patients. Generally people are at higher risk of having side effects if they're older, or they're at higher risk of having things like liver damage and things like that. So they're trying to kind of identify the need of the population or things like that. But it's certainly a very good point, because I do have patients who are older than 75 and they're on cholesterol medications, and they're having side effects, and they want to know, should I be taken off of? So I generally, talk about kind of the risks and the benefits, and I do emphasize that, the guidelines have not really covered elderly patients. They also have not covered, if you notice, kind of younger patients. So I do have some patients who are kind of in their 30s or in their 20s, and they do have high cholesterol, and even after kind of lifestyle changes and things like that, it's still not ideal. So they want to know kind of what they want to know kind of about cholesterol medications as well. So I tell them the same thing. I tell them, it's not well studied, and especially in younger patients, they may be on statins for a good 40, 50, 60 years, and certainly nobody's really studied kind of the long-term side effects. Although I would say statins have been around since around the 80s, so I think we know in general their risk profile. We have a lot of good data on them. So.
All right. And this will be the last question. Your chart showing the ideal diet had off to the left a bottle of red wine in moderate amounts. What is a moderate amount?
So for men, they suggest fewer than 14 drinks per week. So that would be around 2 drinks a day. For women, they suggest fewer than 7 drinks per week. And it's actually interesting because alcohol there is some thought about alcohol actually being beneficial in terms of kind of coronary artery disease or being protective towards coronary artery disease and plaque. Not enough that the medical societies kind of would make a recommendation to increase alcohol intake. But we do know that alcohol can be associated with other things like atrial fibrillation, like heart failure, especially kind of heavy alcohol usage. But in general, like I said, 14 drinks per week for men and 7 drinks a week for women.
All right, thank you. Well, thank you so much, Dr. Huang. It's been very helpful for you to demonstrate to us that a healthy lifestyle, getting our exercise, eating properly, can prevent heart disease, and we can live healthy lives. And that's really an inspiration. So I appreciate, and we all appreciate your emphasis on prevention and moving forward and staying in good health. So we thank you for being with us tonight. And I'd like to say next time we'll have Dr. William Carnes, and he will be presenting on making colonoscopies smarter with artificial intelligence. So we'll be moving down the anatomy. Oh, thank you so much. And good night, everybody.
Thank you all.
Appreciate
Thank you for all your questions.